Yes, madam, we can start. We're live.
Okay. Today we will try to analyze gait, which is called as the signature of the nervous system. So many diseases, when we are unable to find out the type of movement disorder, we make them walk, we get a very important clue. So it is called signature. So we'll see what it is. We shall go through some definitions, then anatomy, physiology, evaluation and classification of gait abnormalities. So first gait has to start from a posture. And a posture is ability of the organism to maintain body parts in desired alignment in balance with the gravitational pull. So that is gait. What is equilibrium? So equilibrium is stable maintenance of posture during rest and activity. When you are resting and when you are active, both situation, body should be in balance. That is equilibrium. And what is movement? So we saw what is posture, what is equilibrium, and now what is movement. Movement is ability of the organism to displace from one plane to another. And it involves short phasic reactions mediated through several reflexes. What are these reflexes? We are having a posture, we are having an equilibrium. After that, with the help of what are we moving? So that involves righting reflexes. So that during posture and movement, our balance is not lost. So you have got postural and righting reflexes. Then anti-gravity stretch. When we move, you are, unlike when we are standing, when we are moving, you have to oppose gravity. So you need anti-gravity stretches. And you have to step, otherwise you will hop. You have to put one leg on the floor and the other should be lifted, and then this one should be lifted and that other one should be on the floor. So you need alternate flexion and extension of the limbs. And during these phases, equilibrium should be maintained. Then only movement takes place. So when you start moving, unlike when you are standing, so many reflexes come so that the balance is maintained. And what is dynamic posture? So we saw what is equilibrium, what is posture, what is movement, and what is dynamic posture. So erect posture during movement. During movement also we do not, unless there is some disease, we do not bend or twist. So dynamic posture is maintaining posture during movement. And what is static posture? Static posture is maintenance of posture while standing still. While standing still also, you should not stoop, you should not show opisthotonus, you should not show Pisa effect, that is side tilting, you should not sway, that is static posture. Dynamic posture is during movement. And both involve very complex coordinated reflex activity which occurs due to afferent input from muscles, joints, vestibular and visual receptors which are received. The information about the position of the body part is obtained and appropriate correction is made. So what is gait? So now we saw posture, equilibrium, movement, dynamic posture, dynamic equilibrium. And so now let us come. So if all these things are there, gait can be initiated. So what is gait? Gait is a learned motor skill. That is the most automatic of all automatic reflexes and can be performed without conscious effort with the erect moving body supported first on one leg and then on the other. So just we can walk. We don't have to plan, we have to think. No, we just walk. So this is a most automatic of all automatic movements and is the most frequently used locomotion phenomena, providing independence and use for many of the activities of daily living. Other methods of locomotion are running, hopping, skipping, swimming, cycling. All these are other methods of locomotion. And gait is called the signature of a person or a disease. And bipedal gait and language makes man a unique animal. So bipedal gait and language is unique for human beings. So evolution of posture happens when the child is born. The child is in the spinal stage. That is, all child does not have any voluntary control. Child is having a flexion of the upper limb, flexion of the lower limbs, and curvature of the trunk. Next is the brainstem stage, when the child will turn over, sit, stand. And next, the third is the cortical stage, when movement starts. So posture evolves through spinal stage, brainstem stage, and cortical stage. So first locomotor movement is observed in the fetus in the 10th week of intrauterine life. And locomotor automatisms with co-activation of agonist and antagonist. That is why the child will be pushing both feet forward or pulling both feet backwards. So there is co-contraction of agonist and antagonist. At the time of birth, this kind of movements will be seen. They push both feet or both hands. And later, this pattern becomes extinct. That is 10 weeks postnatal, this co-contraction pattern changes. And by 7 months quadrupedal, that is crawling. And by 10 months, child will start standing, that is bipedal. And by 3 weeks, near normal gait. And by 4 weeks, the adult pattern of gait is attained. And spinal stage. In the spinal stage, we know that when the child is born, the palm is in the chin and the legs are flexed in the trunk. The palm chin center is in the parietal lobe. So that is why palmomental reflex. This parietal lobe center is suppressed with the development of will that happens through frontal lobe. So when the frontal lobe myelinates, palm chin center will be suppressed and the palm will be taken away from the chin and the thumb will open by 1 month. So palm chin center maintains the palm to the chin, and short latency flexor reflex afferents in the spinal cord that are intersegmental reflexes. They keep the thighs in the abdomen. And here we see the child is just born. Just the chin has moved away from the palm. Otherwise, at birth, the palm is in the chin. And here we see Krishna born immediately, and he is carried to the Yashoda and exchange. Vasudeva is carrying Krishna to Yashoda. We know that this Yamuna is preventing Vasudeva from carrying the baby to Nandagopan and Yashoda. So Vasudeva is confused what to do. He doesn't know the Yamuna water is spilling on the child, and the Adiseshan is trying to protect the baby. But Krishna knew why Yamuna is fighting like that. Yamuna wants to have the feel of the divine feet of Krishna. So he will just extend and drop one feet and touch Yamuna. Then Yamuna will move away and allow Vasudeva to carry the baby. That is the story, how the child was carried by. It's interesting to know all these things, so I thought I'll tell. You see, the child is putting the leg out so that Yamuna gets the feel of Krishna's feet, and then she will settle down and allow Vasudeva to carry the baby. By one, this is spinal mechanisms. Progression is not only by the short latency flexor reflex afferents and the palm chin center, but there are neurotransmitters. There is reticulospinal system which contains the monoaminergic neurotransmitters and carries the short latency flexor reflex afferents. When the short latency flexor reflex afferents are active, the leg will be in flexion only. So that is not what is needed once the child is born. So what happens? The reticulospinal system suppresses the short latency flexor reflex afferents. So extension starts, and the pathways in the spinal cord are released from stretch reflex. Initially, They are only reflex movements. There is no voluntary movements because cortical maturation has not taken place. So, but once the spinal stage progresses to brainstem stage, the reflex movements are suppressed and voluntary component is allowed. And this facilitates voluntary movement. So, suppression of the short latency flexor reflex afferent by the monoaminergic reticulospinal system and the release of the spinal cord from the stretch reflexes facilitates voluntary movement. So by 1 year, the dorsal reticulospinal tract inhibits completely the flexor reflex afferents and facilitates extensor tone. At birth, the flexor tone is the dominant tone. But when the child slowly progresses, the flexor tone becomes suppressed and the extensor tone becomes the dominant tone. The palm chin cinder is inhibited by the frontal lobe. Hands open, child turns over and holds head up. All these are extensor tone mediated postures. So child will turn over slowly, extend the head, then completely go to prone position. Then it will sit and stand. So this is progression to the brainstem stage. When the short latency flexor reflex afferents are completely suppressed, the reflex movements of the various spinal cord centers are suppressed. So the dorsal reticulospinal tract facilitates extensor tone and voluntary component comes into play. So this is the brainstem stage. Then we have the, so this is the brainstem stage. Dorsal reticulospinal tract facilitates extension, suppresses SFRA, and at this stage, as you saw, child will stand. And what is this long latency flexor reflex afferents? Child has stood, but child has to walk. To walk means now at the spinal stage, only flexion was there. In the brainstem stage, only extension is there. And in the walking stage, we need both flexion and extension. So who is going to do this flexion? Because the SFRA is already suppressed. So that is, now you get a long latency flexor reflex afferent, that is the corticospinal tract. That will co-activate along with the dorsal reticulospinal tract. So at one phase, extension will be there, and another phase, flexion will be there. Extension through the dorsal reticulospinal tract and flexion through the long latency flexor reflex afferents. So afferents for, that is the afferents for this. So we should, the body should know which part is in flexion, which part is in extension. So for that, when feet touches the floor, extension is facilitated. So when one feet touches the floor, in that leg extension. So that is the trigger. When the feet touches the floor, that becomes the trigger and the information is sent through the propriospinal afferent pathways. And that is facilitated by the dorsal reticulospinal tract. And when feet swings, flexion is facilitated. So when the opposite leg is in the swing phase, flexion is facilitated in that. And who is coordinating this? Which should be extended and which should be flexed? That is done by the midbrain, spinal cord, and locomotor centers in the thoracolumbar region. So you got two locomotor centers. One is in the midbrain and another in the thoracolumbar cord. Both of them will facilitate this phase-dependent reflex reversal. So the afferents are going through the, so which when the leg is extended, when the leg is touching the floor, extension is facilitated. How the body knows that that leg is touching the floor? Through the propriospinal inputs, through the spinobulbospinal inputs and spinocerebellar inputs through the Knox column. Which part is touching the floor will be conveyed to the higher centers. And walking phase dependent reflex reversal. When feet touches the floor, extension is facilitated. And when swing, flexion is facilitated. And you got the locomotor centers. And the we saw the afferents for this. The efferents are vestibulospinal for extension, Rubrospinal. Vestibulospinal is extension of all four limbs. So we know that the decerebrate posture. Decerebrate posture is mediated through the vestibulospinal tract. When the hands will be extended and the leg will also be extended. That is decerebrate mediated through vestibulospinal. Decorticate is flexion of the upper limb and extension of the lower limb. That is mediated through the midbrain rubrospinal pathway. And corticospinal tract is the long latency flexor reflex afference for flexion. So for peer extension, we have got vestibulospinal. Flexion of the upper limb and extension of the lower limb, we have got the rubrospinal. And peer flexion, we have got the corticospinal. So all these pathways work in a coordinated way so that this walking starts. The child is born in flexion, then turns over by extension, stands by extension, then you get the phase-dependent reflex reversal resulting in combination of flexion and extension that makes the person walk. So a normal person, operation of reflexes maintains the head in a stable position and eyes fixed on the visual target despite movement of the body. So, and the sensors are initiated by vestibular stimulation. When you are moving the semicircular canals, the endolymph will shift and that will say what is the position of the head and the neck on the body. And stretching of the muscles carried through the gamma system will tell about the position of the limbs. And the slipping of the images on the retina will produce the retinal error signal. So when you are moving, the seen object which was first on the retina moves away. So there is a retinal error signal. The neck is moving, so there is a vestibular error signal. And muscles are alternatively moving, so the gamma and the alpha system gives a differential information regarding the stretch on the intrafusal and the extrafusal fiber. So all this gives information about the position in which the body is moving. The responses are the vestibulo-ocular reflex and other precise reflex contractions of the neck and extraocular muscles. So these afferents bring the eye to the target of interest, the limb to the target of interest, getting information regarding the movement that has taken place. The world should be kept in proper attention, and that is done by various reflexes. And what is a senile gait? Senile gait, so after you have got the normal gait, as we age normally, the trunk becomes slightly bent and the limbs become reduced, synkinetic movements become reduced. Person generally moves like a block rather than quickly moving the limbs, upper limbs and the lower limbs. And the stride length short stride length, and leg support widens. So they keep, as we age, slight stoop, bending of the trunk and moving in block, short stance and leg support will widen. So normal gait and balance, therefore, we saw how it is evolving and normal gait and to old age. So how it started in the intrauterine life in the 10th week of gestation to old age we have seen, and normal gait and balance thus depends on the normal function of various structures along the entire neuroaxis from the muscles to the cortex. The structures include from the cortex to the muscles. So we are balancing on a very complex input-output panel. So this is dancing Nataraja. So what is the physiology? So we have seen how evolution to old age happens. When your movement is when you start thinking that you want to go to your office, no, that goes through a cortical influence on the gamma motor neuron and produces a gamma discharge. The gamma discharge is efferent for the intrafusal fiber. So when the body wills a movement, gamma discharge shortens the intrafusal fiber. But at this time, the extrafusal fiber is unaltered. Intrafusal fiber and the extrafusal fiber are longitudinally aligned in balance. When the intrafusal fiber contracts and the extrafusal fiber is unaltered, there is a mismatch between the intra and the extrafusal fiber. And this is called alpha gamma error signal. Alpha is for the extrafusal, gamma is for the intrafusal. Because you have built a movement and that comes to the cortex and enters the gamma motor neuron, the intrafusal contracts, but extrafusal is not contracting. Therefore, the proportion is lost, resulting in a error signal between the alpha and the gamma. This error signal is sensed and it is carried by 1A fibers to alpha motor neuron in the spinal cord. This alpha motor neuron will activate the extrafusal fiber to contract proportionately to the intrafusal fiber. If extrafusal fiber is stretched, first reverse. So when you will a movement, it is through the intrafusal fiber. Instead, somebody is stretching your limb and telling you, pulling you to move apart. Then it is not, it's a reverse. The extrafusal is stretched first, and this in turn activates the intrafusal fiber. So this is called alpha gamma co-activation. They are always co-activated, either whether it is a willed movement or an enforced movement. So alpha motor neurons facilitate agonist and inhibit antagonist and serves as a length server, correcting error signal at gamma. As you know, gamma is intrafusal, alpha is extrafusal. They are in balance and they are mediated through the gamma motor neuron, which is controlled by the higher centers, that is called gamma motor system. And the alpha motor neuron is efferent to the extrafusal fiber. So these two co-activate so that whenever the intrafusal is contracting, there's a proportionate movement on the extrafusal and vice versa. So the factors involved are the tone of the muscle, which is controlled by the stretch reflex. The stretch reflex in turn is a spinal reflex influenced by higher supraspinal centers and higher centers influenced by afferents, which cause certain reflexes called postural reflexes. So based on the afferent inputs, when you move forward, the supraspinal influences bring out postural and writing reflexes so that body is still maintained without falling when you are moving. So this is the nuclear bag fiber, nuclear chain fiber, part of the intrafusal fiber. Here you can see the gamma efferent that is coming from the gamma motor neuron. This is the one which is activated when we will a movement. And in turn, the alpha motor neuron will be activated and the extrafusal fiber will contract. Whereas the afferents are through the 1A afferents, the alpha motor neuron, which go and supply the extrafusal fiber. So combined working of the intrafusal and the extrafusal is necessary so that there is appropriate contraction of the peripheral structures like muscles when you are moving. So gamma system determines the spindle sensitivity. For how much stretch the muscle spindle should activate the alpha gamma coactivation and the extrafusal muscle should be put to activity. And alpha motor neuron is extrafusal fiber activation. So gamma system decides the spindle sensitivity, alpha motor neuron supplies the extrafusal fiber, and beta or skeletofusiomotor, they connect both extrafusal and intrafusal. So gamma is for intrafusal, alpha is for extrafusal, and beta is for both intra and extrafusal. And Renshaw cells cause recurrent inhibition and modulates and stabilize firing pattern. So this is the supraspinal mechanisms which act on the gamma motor neuron, and gamma motor neuron in turn supplies the intrafusal fiber. That is the gamma motor system which maintains the sensitivity of the muscle spindle. So as I told, when the movement is willed, gamma is stretched. When the person is mechanically pulled, the alpha is stretched, and there is a co-activation of alpha and gamma. Either it's a willed movement or an enforced movement. Enforced movement, extrafusal structure, skeletal muscle structures, and secondarily the intrafusal structures. Willed movement, intrafusal structures, and secondarily the extrafusal is stretched. However, there is a coordination taking place in the spinal cord, which is controlled in turn by the supraspinal mechanisms. And group 2 afferents cause flexion of the stimulated limb. They are therefore called flexor reflex afferents. That is what is very active at the time of birth. Group 2 afferents flexion of the limbs. They are called flexor reflex operands. When a voluntary movement is willed, FRA is inhibited by corticospinal modulation. And vestibulospinal tract increases the tonic vibration and facilitates alpha gamma excitability. And in the spinal cord, we said there are locomotor centers in the midbrain and in the spinal cord. They only coordinate, which should be agonist, synergist, and fixator, antagonist. That kind of thing is done by the central pattern generators or the locomotor centers. And the central pattern generators are there in the spinal cord as well as in the midbrain. And it is having three important functions. Setting the activity of the central pattern generator to determine the initiation and speed of locomotion. So if you are in a beauty contest, you have to slowly move. And if you are in the fight or flight situation, you have to quickly move. So that which is to be done, that pattern is set up by the central pattern generators and setting the postural tone. So after the pattern is decided, the tone of the appropriate muscle should be determined and modulating the force generated by the muscles activated by the central pattern generator. So central pattern generator decides the initiation and speed of the appropriate locomotion needed at that time. And this in turn alters the postural tone and determines the muscles to be activated and muscles to be inhibited. And as I said, supraspinal mechanisms, one is the gamma motor neuron, alpha motor neuron, Renshaw cells are there in the ventral horn. Gamma is for intrafacial and spindle sensitivity. Gamma in turn receives inputs from cerebellum, basal ganglia, and cortex. Information through all this will decide for how much intrafacial contraction the extrafacial should contract or relax. And inhibitors of these supraspinal mechanisms are corticospinal, cortico-reticulospinal, dorsal reticulospinal, and ventromedial bulbar reticulospinal. So there is an inhibitory and facilitatory input on the alpha, gamma, and Renshaw cells in the ventral horn. The inhibitors are corticospinal, cortico-reticulospinal, dorsal reticulospinal, and ventromedial bulbar reticulospinal. Whereas facilitators are vestibulospinal, cerebellar, and medial reticulospinal pathways. And the centers which induce locomotion in the supraspinal region are mesencephalic. That's the midbrain locomotor center, which I was telling, mesencephalic center. Then you have got a subthalamic locomotor center, and we have got a dorsal and ventral tegmental field, and we have got a pondo-bulbar locomotor region and cerebellar locomotor regions. So for the supraspinal, that is in the ventral horn, alpha, gamma, and Renshaw, and there dorsal reticulospinal, ventral reticulospinal, FRA, and LFRA. And above that, we have got the mesencephalic center, subthalamic center, ventral tegmental field, pondo-bulbar locomotor region, and cerebellar locomotor region. Cerebellum remains the force and timing of the locomotor and postural responses, and basal ganglia, through interaction with the brainstem nuclei and cortex, fine-tunes the movement. And for the skilled walking, graceful walking, cortex is needed. And area 4 is the motor area. Area 6 is the supplementary motor area. And others are association areas. Then you have got the basal ganglia, cerebellum, and they act via the gamma motor system. As you saw, it's a gamma motor system, is supraspinal, spinal, and efferent to the intrafacial fiber. So this is, in short, what we saw as the control mechanism. First, we saw the evolution of posture and gait. Now we saw the control mechanisms, that is from the cortex, through the midbrain, to the spinal cord, then to the muscles. So that is what we went through now. That is diagrammatically depicted how the physiology of locomotion is taking place. So for reflex standing, vestibulospinal and pondo-reticulospinal facilitate flexion of the upper limbs and extension of the lower limb. So normal standing posture is through the flexion of the upper limb and extension of the lower limb. And medullary inhibitory reticulospinal tract inhibit this posture. So when then there is a lesion between the midbrain and the medulla, this posture cannot be maintained. As we saw initially, rubrospinal pathway is needed for this standing position where the upper limb is flexed and lower limb is extended. When there is a section between the midbrain and the lower brainstem, this posture cannot be. That's a reflex standing posture cannot be adopted. And as we said, when vestibulospinal is extensor, or decerebrate, as I was saying, no? Then let us see, when an animal falls from a height, there are several reflexes. These are the reflexes which act during locomotion. They are called righting reflexes. Righting reflexes are reflexes which help to keep the normal posture during varying types of movements. So these are head rotates. That is head rotation, so that you focus on where you are falling. That is done through the labyrinthine righting reflexes. The neck on body righting reflex, they are called neck righting reflexes. Body upon trunk, they are called body upon trunk righting reflexes. And landing on the floor is the vestibular placing reaction, so that we land without injuring. We may remember this picture in our physiology textbook, where very comfortably using all these righting reflexes, the animals fall without injuring themselves. But human beings have the willed movement through the advancedly developed cortex. Because of that, these righting reflexes are weak. So if our will is less, we injure ourselves. For lower animals, the righting reflexes themselves are enough, and the role of the cortical righting is less. So now we see what are all the reflexes that are happening when this animal is falling. We saw it has to see, rotate the eyeball, stabilize the head on the trunk on the body. So many things are there. So first group of reflexes are anticipatory reflexes. When you are crossing a road, you are anticipating buses, cars, autos, cycles, like that. So they are the anticipatory reflexes for a presumed obstacles which we are going to see. Reactive reflexes are unanticipated. Suddenly a dog is running in the road. So that's a reactive reflex to an unanticipated target. And rescue, something has happened. Already some vehicle has hit us. Then how are you going to get back to normal activation? They are the rescue reactions. And protective reactions are reactions which in the face of an insult help to protect the vital structures of the organism. So with the reflexes involved are anticipatory for normally happening default activity, reactive for unanticipated, rescue for actions which have already happened, but you are trying to protect the organism with minimal injury. That is the rescue and the protective reaction. So these are the various reactions very active in the animals because they are not voluntary. They are reflex. The neurotransmitters involved are in the basal ganglia to pedunculopontine nucleus is GABA, and in the reverse pathway, it is acetylcholine and glutamate. And controlling this whole thing, the anatomy and the physiology is done by the system called neuronal traffic control system. So posture is both willed and involuntary. You know that most of the time we want to sit erect, but there is a large amount of involuntary component. But the mechanisms are not willed. Spinal proprioceptive impulses and their descending control from the higher center is important. And it is this group that we saw, the cortex, cerebellum, basal ganglia, the brainstem network, the pattern generators, locomotor centers, which come up to the intrafusal fiber. This whole network is called neuronal traffic control system. But voluntary movements are superimposed on motor demands and they need cortex. For example, so all this is happening for an anticipated normal activity. When there is an unanticipated activity superimposed, we need the cortex to plan and decide which is the best one to, best direction to move when there is an unanticipated movement. When a decision is made to execute a previously learned movement, impulses derived by the corticospinal and cortically originating extrapyramidal system show the default mode information of that learned motor schema which is executed. And they recall positive feedbacks from cerebellum and thalamus for error correction and for feedbacks. So when we are standing, center of gravity falls near the pelvis through the spine. And you have got a base of support and it drops at the center of pressure located between both feet. So center of gravity falls near the pelvis through the spine. And base of support drops at the pressure, center of support drops at the center of pressure located between both feet in the midline. So this is needed for stable standing. And when locomotion starts, when you start moving, center of gravity shifts forward. So you have to shift along with that the base of support. So only you can move. When you start locomotion, center of gravity moves forward. Then base of support also should move forward. Then only you can move forward. So a step is needed. So center of gravity has shifted. So how I have to take a quick movement so that my base of support also shifts forward. So for requirement, for this, we need balance and erect posture. We need gait initiation. Then we need generation of rhythmic locomotion and adaptation of movement based on demand. So normal posture, normal initiation, normal rhythm. In addition, for new demanded movements, you should be ready. And this is one anti-gravity stretch. We are standing, the gravity is pulling. You have to oppose the gravity. So that is anti-gravity stretch, moving the center of gravity laterally to one foot. So anti-gravity stretch, slowly you move the center of gravity laterally to one foot. And stepping, alternate movement of the leg. So anti-gravity stretch is needed so that you take your foot off the floor and then alternate movement of the leg, stepping and equilibrium, adapt to change in speed, turns, surface, and unexpected body displacements. So all this will happen and you have to maintain equilibrium. And that is done mainly by cerebellum. And propulsion is feedback from loading and unloading limb, helps in inter-limb coordination. So loading limb is the weight-bearing limb. Supposing the right limb is extended, that is the loading limb. And left limb is flexed, it is the unloading limb. So proprioceptive afference from this loading and unloading limbs goes to the higher centers and helps them to work in a coordinated fashion. And upper limbs move synkinetically in semi-flexion along with the contralateral leg. If the leg is moving forward, the right leg will be in flexion. And chest makes minor forward excursions. So of this initiates gaze. And now the gait cycle is coming. It consists of two regularly alternating phases, either of the two lower extremities. So heel, gait starts by the heel contact. The heel of our feet touches the floor. The heel impacts starts the stance phase. So first only we saw the limb that is touching the floor is promoted to extend by the locomotor center and the central pattern generators. So the heel impact, when the heel touches the floor, that leg goes into extension. And as the toe leaves the floor, first the heel comes, then the toe comes, and then the toe leaves. When the toe leaves the floor, the swing phase starts, and then the flexion is facilitated. So first is the heel contact, then the toe comes to the floor, then toe is elevated. At that time, flexion is facilitated because that limb is removed from the floor. Flexion is facilitated. When both feet are on floor, that is called double support phase. Very brief period of gait cycle. Both feet are on the floor, that is called double support phase. And what is a stride? Two strikes made by the heel of the same foot. So the right heel starts the gait, then the right toes come down, then the left heel starts, left toes, and then the right heel. That is a stride. Stride is two heel strikes by the same leg. And cadence is number of strides per minute. So these are the typical gait parameters when you do gait analysis. As I told, the swing phase, the double support phase, and the heel support phase. So you have got velocity, you have got cadence, you have got stride length, you have got stance, swing, and double support. These are grossly the values. They change based on the weight, the height, and the dynamism of the individual. But these are standard values. So gait cycle has got a stance phase, a swing phase, and swing phase starts when the toe clears, and stance phase starts when the heel strikes, and weight acceptance by that limb which is in stance and a single limb support. So weight is accepted by one limb and that limb supports, and then it has got an initial contact, then the loading response, and the mid stance and terminal stance. So this whole is the stance phase or the limb which is touching the floor. Next is the swing phase that has cleared the floor. So that is limb advancement, pre-swing phase, initial swing phase, mid-swing phase, and terminal. This is the sub-classification of the stance and the swing phase in the gait assessment equipment. So that which part of the stance or which part of the swing is affected can be analyzed. So what is the contact period? Heel strike to forefoot loading is called contact period. The heel is striking and then the forefoot is touching the floor. That is the contact period. Period between the heel strike to forefoot touching the floor is the contact period. And foot pronates at subtalar joint. We know the talocalcaneonavicular joint or the subtalar joint. The foot pronates at the subtalar joint after that. And this is the only time normal pronation occurs in the subtalar joint. Normally, these movements now do not occur. It is happening only during the gait cycle. And this absorbs shock and adopts foot to uneven surfaces. And leg is internally rotated and ends with metatarsal heads contacting the ground. So heel strikes to forefoot loading is the contact period. And during this period, there is pronation at the subtalar joint. And this absorbs shocks and adopts the foot to uneven surfaces. And leg becomes internally rotated. And then it ends with the metatarsal heads contacting the ground. That is the contact period. Contact period means heel strike to the toe strike period. Next is the mid stance period. Forefoot loading to heel raise. So forefoot is loading. Therefore, what happens? The first thing is the heel that is on the floor. When the forefoot is loading, heel will rise. And foot stops pronating. It is pronating and doing shock absorber work, we said, no? That pronation stops. Instead, there is supination due to tibialis posterior and soleus contraction. And an external rotation of the leg takes place. And the other leg is in the swing phase. So all weight is in one foot, which is on the stance phase. In the mid stance phase, all weight is in one foot, which is in the stance phase. And body is directly over that foot and ends as heel leaves the ground. Next comes the propulsive period. So stance phase, mid stance and initial stance we saw. Then you are going to propulsive phase, heel raise to toe off. So heel has raised, toe has touched it. And propulsive phase starts when the toe is off. So stance phase is from the heel to the toe. When the toe is off from the floor only, the propulsive phase starts. And subtalar joints supinates continuously until just after toe off. Till the toe is off the floor, there is supination taking place again at the mid-talar joint. And leg continues to externally rotate. And forefoot only bearing weight on this side. And forces move from lateral to medial, passing through the hallux. And first metatarsophalangeal joint must function correctly for maximum efficiency of this propulsive period. And the toes are loaded to stabilize the metatarsophalangeal joints. Next comes the swing phase. Foot accelerates to catch up. So foot will accelerate to catch up with the center of gravity. And leg internally rotates from the externally rotated position. And foot pronates to aid ground clearance. And foot decelerates and slightly supinates in preparation for the next heel strike. Normal standing position, feet is slightly abducted and shoulder width apart, knees pointing forwards and extended, heels are vertical, angle is 90 degrees to the leg. All metatarsophalangeal joints and toes are in contact with the ground. Walking is upright attitude. So hip, knee and pelvis slightly flex, we know that. And uploaded limb passes forward. That is the limb which is crossing from the stance phase to the swing phase, passes forward. And the upper limb swings with the contralateral leg. If the right leg is moving forward, the left leg will swing along with that. That is a physiological synkinesis. And what is double support phase? We saw that in the gait cycle, there is a double support phase. The double support phase is the phase when both feet are on the floor. Very small part of the gait cycle where both feet are on the floor is the double support phase. And in running, double support phase is sacrificed. So there is no double support phase when we are running. And for jumping or jogging, it is not running. It is a series of jump and increased amplitude. That is jogging. The running movement, only the double support phase is not there. Stance phase and the swing phase is there. Whereas for jogging, there is only jumping. There is no stance or phase. And balance during movement. Ability to maintain balance under dynamic conditions is the is planned in the direction of motion and in the plane at any angle to it. So in the direction of motion or at any angle to the dynamic movement that is taking place. So walking continuously makes up for center of gravity shift. Center of gravity shift is happening in front and basic support should move forward. And anticipatory postural reflexes ensure adjustment prior to intended activity. And reactive postural reflexes adjust to sudden change of external condition, unanticipated conditions. And so this is about the physiology part. Now we will see evaluation. Gold standard is the patient observation. Observe the patient while he is walking. That is the best method. And this is done through a neurological evaluation, getting up from lying to sitting, sitting to standing. Then stand, base, width and posture. Then maneuvers during standing or feet close and eyes open. Then Romberg's test, that is eyes closed. Then during verbal distraction, patient is standing, you are distracting. Is he able to balance? Then push test or full test and one limb and tandem test. So that is the sit, stand, walk test. Then a spontaneous gait, how are you going to observe? Bandwidth, stride width, cadence, fluidity of movement, deviations from the normal movement, start, stop, turns, walking through narrow passage. Bandwidth, base width is the distance between both feet. Then stride width is the distance between 2 feet while walking. The number of strides per minute is the cadence. Fluidity is the synkinesis. When the right leg is moving forward, left arm should move forward and vice versa in a very smooth way. And then you have to do start, stop, turn. Tell the patient start walking, then suddenly stop and suddenly turn. All this will bring up minor abnormalities in gait and balance. And then walking through narrow passages, tandem walking. Then anti-gravity stretch. So when there is an anti-gravity stretch, stepping, equilibrium, propulsion, all these can be tested. There is a gait ignition failure or magnetic gait when there is an anti-gravity stretch failure. Stepping is defective in long latency, flexor reflex afferent abnormality, so the patient will be dragging. Equilibrium is defective, swaying or reeling. Propulsion is defective, is slow. So stands, space, turns, climbing up, climbing down, walking tandem, walking on heel, walking on toe, all should be tested. Then tandem walking, walking Romberg's. Normal Romberg's is eyes closed and legs together. Walking rhombox is leg in front of another. Then walking backwards, walking on heel, walking on toe. Then in the laboratory. So first is the bedside. Laboratory, stand, walk, sit test. Ask the patient to stand from the chair, walk quickly to your mark and return back and sit down. Step seconds test. Number of steps, stride length, duration calculated within a fixed distance walking. Then simultaneous task test. That is, you distract and see what happens the gait. And using small appliances, foot switch. The whole thing can be videographed. Attach a foot switch to the patient's foot and it will make a video record of the gait cycle. And task-linked analysis, addition of competitive task to walking worsens mass subtle abnormalities. For example, when the patient is walking, you feel that nothing abnormal is coming out, but patient says that there is some disequilibrium, then tell him to do a mental arithmetic. When he does mental arithmetic and walks, the imbalance will be brought out if it is an organic subtle defect. If it is psychogenic, the gait will improve when distracted because psychogenic gait is voluntarily generated by the patient. So when you distract him, he cannot concentrate on the gait that is producing. So his gait will improve. And sensory stimuli, visual or auditory, improves freezing. Freezing is sudden stopping. So that will improve by visual or auditory stimuli. And such stimuli unmask unsteadiness. Then you got gap scale, where you got 7 marks for history, physical examination 18, and time duration task 3. And based on that, you can find out what is the abnormality. Then abnormalities are categorized as lower level, middle level, and higher level. Lower level is for muscle, nerve, spinal cord, and proprioception. Middle level is for basal ganglia, cerebellum, and perception based. And higher level is synergy selection and adaptation to new circumstances, mostly relating to attention, insight for adaptation, and personal goals. So these are very cautious gait. It will appear that patient is very cautious rather than having a gait abnormality. That is the higher level gait abnormality. Middle level, lower level, higher level. That is the classification by Nutt. LMN, hip abductor weakness means hip tips towards the swing leg. So there will be Trendelenburg effect. To compensate for this, lumbar lordosis will occur. So the leg will tilt out and down and exaggerated lumbar lordosis. And trunk fluxes towards the support leg. So trunk will flux. So you get lumbar lordosis, flux and tilt to one side. And hip and trunk swings from side to side to compensate for difficulty in rising. And alternating collapsing of the hip or waddling or duck gait happens due to hip abductor weakness. And there can be a combined involvement of several muscles resulting in what is called as a myopathic climb. Then LM distal, so LM proximal, anterolateral group. If there is involvement, there is excessive knee and hip flexion. And foot drops with great toe on the floor. And that is called high stepping or cock gait. When the posterior group is involved, there is slapping. When the posterior group is involved, patient is unable to hold in dorsiflexion, so slaps and falls. Pushing, so that is a slapping gait. Just the foot will fall down. Then human start hesitation. When you are starting, you are hesitating. That happens with apraxia. Then start shuffles, otherwise called slipping clutch phenomenon, extrapyramidal disorders, fascinating or shuffling and increased pulsion, and freezing is motor block, sudden block. So hesitation, start hesitation can be due to apraxia, it can be due to slipping clutch phenomena, it can be due to fascination, or it can be due to freezing. And stepping is one when is extended, other should flex. That is lost when the long latency flux or reflex afferents are lost. That is spastic paraparesis, spastic hemiparesis, dystonic hemiparesis, and akinetogenic syndromes. And next is equilibrium, that is cerebellar and vestibular. So side to side swaying or reeling. And thalamic gait is normal strength but marked disequilibrium and bizarre gait. So higher level gait problems, what are they? They are more cautious cognition related disorders, and gait characteristics more non-specific. Unlike cerebellar gait or corticospinal gait or muscle gait, they are non-specific. So it is called gait apraxia, and they are glued to the floor. They feel that the X-magnetic field is pulling them, and cognitive dysfunction may be there, resulting in slowed processing, and they can have behavioral problems and fear of falling. We should always look for deformities and lesions. We should not straight away fix that any gait abnormality is neurological. It may be orthopedic, it may be related to tendons, which are easy to correct. So always look for deformities and non-neurological lesions. Check restricted movements. Check muscle tightness, like tendon shortening, and do neurological and vascular assessments. Apart from the gait analysis, do not forget to look for all this. What is freezing? Freezing is brief episodes of inability to initiate or continue locomotion. It happens during change or stress. So suddenly when you are changing, the patient becomes stuck like a log of wood. It happens at initiation, during locomotion, or during testing circumstances. And response motor or behavioral tricks, like you can put a colored book or target in front or play a music, then the freezing will improve. That is another kind of trick in movement disorder. So biggest problem in gait is falling and injuring. So what is a fall? A fall is defined as an unexpected event in which the person comes to the ground or floor suddenly or lower level, not due to a seizure or a stroke. And fall calendar is documentation of the falls in people who fall frequently. That is very important. And you have to find out the semiology of the fall. And multiple faults are defined as having at least 2 faults or more during the test period. Injurious faults are well-defined faults that provoke skin damage, laceration, and cause injuries. They are labeled as injurious faults. So gait, we can put based on the clinical abnormality, continuous abnormality. They occur continuously during locomotion. They are not intermittent, unlike freezing or shuffling. They are always present and can vary in severity. Typical example is ataxia. It persists always. It can be sensory ataxia, it can be cerebellar ataxia, or it can be vestibular ataxia. Then you have got spastic gait, where there is increase in the tone and dragging. It can be hemiparetic or paraparetic. So it can be continuous gait disorders which are present always, or ataxic or spastic, and bradykinetic or hypokinetic, dyskinetic, choric, dystonic, and paretic associated with muscle paralysis, and trunk abnormalities and partial abnormalities, and andalgic gait due to painful conditions where you limp. And you can have apraxic gait in frontal lobe, anxious or fear of falling, and cautious gait in higher order gait disorder. Bizarre gait can happen in psychogenic and proprioceptive dysfunction. Severely depressed patients and psychogenic patients produce uncharacterized gait disorders. Undetermined, sometimes they may be difficult to classify. And so they are called undetermined gait disorders. They may have more than one structure involved. Then what are these episodic gait abnormality? They occur intermittently. They are freezing, festination, episodic disequilibrium, and mixer types where the patient suffers from more than one type of abnormality. We saw the lower level, middle level, and the higher level. And fall syndromes may be collapsing falls when they suddenly collapse and fall. That is akinetic seizures, syncopes, and orthostatic hypotension. Whereas toppling falls happen when they are standing and while changing position, they are toppling falls. Then you may trip and fall, you may freeze and fall, and you can have unpatterned falls. So falls in older person is the major concern, and you may have a gait disorder, you may have a postural instability. This will lead to fractures, other injuries, or psychogenic problems. They stop moving. fear of falling, they stop moving, and there is immobilization. That results to a lot of complications, and later the patient becomes bedbound and damaged. So we have to be very careful and categorize the type of fall and help them to prevent the fall. So you have got vestibular system as otolith and semicircular canal. Otolith are related to static equilibrium and semicircular canal due to linear acceleration. So during movement related disequilibrium occurs in semicircular canal, whereas static disequilibrium occurs due to otolith dysfunction. And vestibular falls, eyes closed, falls the side of disease, and head to the side of pathology, falls backwards as the canal which is pointing posteriorly. Then if head is turned to side away from the disease, they fall forward, and cerebellar falls, disease reeling in archicerebellum and swaying in paleocerebellum, and vermis, they fall anterior-posterior. So cerebellar disease, you have got decomposition of gait. We have discussed this in the session on cerebellum in detail, how dyssynergia happens, and dysmetria due to delay in antagonistic burst, that is nucleus emboliformis. No? Balance and gait affected due to impaired anticipatory adjustment. We saw anticipatory adjustments are there, unanticipated adjustments are there. So if anticipatory adjustments are impaired, they can be abnormal or double support phase, poor limb coordination. So that is the afferent inputs from the moving forward, backward limbs will give information that coordinate both the limbs. That I have told. When that information is poor from one limb, the coordination fails, and oculomotor disturbances due to retinal error, VO or leaky neural integrator, all this leads to imbalance. And alpha gamma coactivation also we have discussed in the physiology. If that is not there, intrafusal is contracting, extrafusal is not, or vice versa. So the willed movement or the executed movement becomes erratic. So when there is somebody falling, are they falling with consciousness, without consciousness? Without consciousness, seizure or syncope. With consciousness, vertigo, non-vertigo, Tomalkin's crisis, that is in many years, or central vertigo, non-vertiginous toppling, tripping, freezing, unpatterned falls and buckling. Psychogenic falls are multi-directional. They do not try to open eyes. Toes become extended and they improve when there is dual tasking. Treatment, treat the cause always. Make environment safe. If there is a person who has got like a PSP syndrome, where there is no effective treatment, then make the environment safe, soft flooring, and you do not put complicated objects in the areas where the patient is ambulant, and mechanical assistance when needed, and gait training, patient standard gait training. So what are the benefits of walking? It lowers the body mass index, lowers blood pressure and cholesterol, lowers fasting blood sugar, and better memory and cognitive function, and lowers stress and improves mood, longer life, and walk as much as you can and pick up the space. Lose weight by living in a walkable neighborhood, and walk to combat cancer, walk to reduce heart disease, walk to reduce blood pressure, walk to reduce diabetes, walk to keep arteries unclogged, boost mental health by walking, and walking combats joints and muscles. So we have gone to anatomy, physiology, pathology, testing, and grossly the template for diseases. So we have understood we are nothing before the power, the author of this universe. Every small phenomena in the human body is so complex. So ultimately, we end up doing just a small template of the phenomena which we have chosen to discuss. And so we are endowed with the intelligence and guides us in the path of dharma. Dharma means to uphold, nourish path towards ultimate realization and righteousness. So bliss is union with that Paramatma. Ultimately, it is that. And we do not bleed, we do not clot. We have got bleeding factors, we have got clotting factors. But we do not bleed, we do not clot in the north. We do not swell, we do not shrink. We do not stoop, we do not fall. We saw how we do not fall. or because we are balancing, and that is the complexity of life. Thank you. Any questions are there, I can answer. Are there any questions? Shall we stop? Should we stop, or any questions to be answered are there? Should I stop? Doctor, nobody's there, huh? Should we stop or not?